Rebecca, hi Martine, good morning.
Good morning.
Morning, Peter.
And
Good
I'm gonna
morning,
just get
Martin.
set up here. I'm gonna get my backup dialed in and get the deck uploaded, and I'll put us in a practice session here shortly as well. But if
Nice.
you guys need anything, give me a shout.
All right.
All right.
Okay, moving into a practice session now here. Hello, and welcome to today's Let's Talk About Health, Sickle Cell Disease webinar. My name is Peter, your WebEx producer, and I'll be in the background answering any WebEx technical questions. We have a few housekeeping items before we get started. If you experience technical difficulties, please send a message to myself using the Q&A panel. You may also dial 1-866-779-3239 and receive WebEx technical support assistance. During the presentation, all participants will remain in listen-only mode, and as a reminder, this event is being recorded for rebroadcast. We encourage you to submit written questions at any time during the presentation using the Q&A panel at the bottom right of your screen. Please type your questions into the text field and hit send. Please keep the drop-down as all panelists. I would now like to introduce your first speaker for today, Donna Jacobs. Donna, you now have the floor.
Thank you so much, Peter, and thank you for those logistical comments. We appreciate it. Good afternoon, everyone, and welcome to Let's Talk About Health, a community conversation. I am Donna Jacobs, as Peter said, and I will moderate today's program. The University of Maryland Medical System's Let's Talk About Health series is designed to do a few things. We've been doing this for about 2 years now, once a month. It's designed to increase awareness about critically important health topics, to provide people with the tools to help them maintain and improve their individual health or that of their families, and thirdly, to improve conversations that patients have with their providers. Sickle cell is the topic of the month. Next slide, please. September is Sickle Cell Awareness Month. And obviously, for that reason, we're here today to speak to you about sickle cell disease. I'm so pleased that you all have been able to join us today. Also joining us are two very knowledgeable speakers whom I am pleased to have with us. And it's been a pleasure to talk with them over this last month as we got ready for today. The first speaker will be Martine Bell, and she's senior nurse practitioner for the Sickle Cell Care Coordination Team at the University of Maryland Medical Center downtown. She holds a doctorate in nursing from Drexel University. She was first a bedside nurse, but now has 18 years of experience as a nurse practitioner. And I must say that Dr. Bell is in her element today as she is passionate about health education and community service. Thank you, Dr. Bell. We also are very blessed to have with us Tiana Wolford, who has graciously agreed to speak to us really from two perspectives today. One is personal and one is professional. She has sickle cell anemia and has fought many resulting health complications, including bilateral hip replacements and a failed bone marrow transplant. Nonetheless, she perseveres. She's the founder of and CEO of a new nonprofit organization, the Sickle Cell Reproductive Health Education Directive. And she's contributed to many publications and discussions with the American Society of Hematology and the National Health, Lung, and Blood Institute. Welcome to you both. Let me say this. The webinars in this series are virtual conversations, and we've enjoyed that. It was precipitated by COVID, but it gives people an opportunity to really participate during this lunch hour. But nonetheless, despite being virtual, they're designed to be interactive. So as Peter said, if at any time during the conversation you have a question, please feel free to type it in the Q&A box, not the chat box, but the Q&A box, and our conversation leaders will be happy to address as many questions as our time together will permit. Let me also note for you that we will not be able to address individually based medical questions, as we can't do individual diagnoses over this call, but we're happy to answer your important questions that relate to your audience, our audience, in a general way. Again, this conversation is being recorded, and you will have an opportunity to see the recording again if you choose, share it with someone at a later point, and see the slides that will be presented. And I'll give you more information about that as we go along. All right, as we get started, let's go to the next slide. Let me explain that we have cast these discussions, these community conversations, in a way, as I mentioned, to help improve communication between patients and their providers. And one of the very successful ways we find that that can occur is by using the Ask Me 3 model. And it simply is, once a patient describes a scenario, you have a concern in your mind that you'd like to have addressed, you think about 3 questions that we believe provide a great bucket for making sure you get what you need. You ask the questions that you need, and then you have a container to help you retain the information that you've heard. So those questions are 3 simple ones. What is my main problem? What's the issue? What's my main problem? What do I need to do about it? And then why is it important for me to do that? And that will help you retain that information. Dr. Bell is going to share just one example of how Ask Me 3 might work, but certainly you can apply it to any situation that you might have personally. So those 3 questions: what's the problem? What do I need to do? And why is it important? All right. And with that, Dr. Bell, maybe we can start with you.
Great, thank you so much. As stated, my name is Martine Bell, and I am the nurse practitioner for the sickle cell team at the University of Maryland downtown campus. I just want to start by thanking Donna and the rest of the team for the invitation to come speak about sickle cell disease during Sickle Cell Awareness Month. Sickle cell disease is a disease that in the past did not get much discussion or attention from the medical and research community. But we're in an exciting time right now where there's a lot more funding and a lot more research that's being done. So we are really moving forward. So this is a really exciting time to talk about sickle cell disease. So I'm very happy to be here. So we're going to start with some facts about sickle cell disease. What is sickle cell disease? It is a painful genetic condition that's present from birth. It's the most common inherited blood disorder in the United States and affects approximately 100,000 Americans. And it most commonly affects those of African, South or Central American, Caribbean, Mediterranean, Indian, or Saudi Arabian descent. So as you can see, that this is a disease that mostly affects people of color. Next slide, please. 1 out of every 365 Black or African American babies are born with sickle cell disease, and 1 out of every 16,300 Hispanic American babies are born with sickle cell disease. 1 in every 13 Black or African American babies are born with sickle cell trait. And this is a really important distinction to make because a lot of times people will get sickle cell disease and sickle cell trait confused. Sickle cell trait means that you have the trait for the disease, you're a carrier for the disease, but you do not have the fully expressed form of the disease. Next slide, please. Taking a look at the history of sickle cell disease in the United States. In 1904, a 20-year-old dental student named Walter Clement Knoll presented to Chicago Presbyterian Hospital with symptoms of anemia. He was treated by a medical intern named Dr. Irons, who noticed that this patient's blood work was showing what he described peculiar, elongated, and sickled state, that's really hard to say, red blood cells. He presented this to his attending physician, Dr. Herrick, and the two of them did some research, and in 1910, they published a paper in the Archives of Internal Medicine documenting the first known case of sickle cell disease in the United States. Fast forward about 40 years, we see Dr. Linus Pauling and his colleagues who were doing research and demonstrated that sickle cell disease occurs as a result of an abnormality in the red blood cell. And then moving ahead another 50 years, the FDA approved hydroxyurea for the treatment of sickle cell disease. And this was the first major medication that was used to treat sickle cell disease. Prior to that, hydroxyurea was just being used for patients with cancer. Looking at this slide here, we see some healthy red blood cells and we see some sickled red blood cells. The ones there that look like donuts are what healthy red blood cells look like when you look at them under a microscope. And then the crescent ones are ones that have taken on a sickled shape. When those red blood cells break down and they take on a sickle shape, they become sticky on the outside, and that stickiness allows them to be able to clump together. When they clump together and they block a blood vessel, such as the eyes or the heart or the lung, skin, bone, wherever, it's a very painful and dangerous process. And the reason for this is that blood is not able to get to the other side of where that occlusion is. And if blood's not able to get there, oxygen's not able to get there either. And the tissue starts to break down and starts to die, and very painful and very dangerous. Next slide, please. Here are some signs and symptoms of sickle cell disease. The first one that usually occurs happens in children under the age of 2, and that's called dactylitis. This picture here shows a child with dactylitis, and dactylitis is a swelling in the joints of the hands and the feet. That occlusion that was shown on the previous slide is occurring at the blood vessels to the joints in the hands and the feet, and it's causing it to swell and be very painful for the child. Prior to the 1990s, in the United States, there was no universal testing for sickle cell disease in children at birth. After the 90s, they've done it across the United States, but prior to the 90s, this was often the first sign that a child had sickle cell disease. Next one is pain. As stated before, this is a very painful disease. Yellowing of the skin or of the eyes can also occur. Fatigue can also occur. These are only just a few symptoms. There's a whole myriad of symptoms that a person with sickle cell may experience. These symptoms may vary from person to person, and these symptoms also can change as the person gets older. Sometimes they get worse, sometimes they get better for a while and then get worse, but it can change from person to person as they get older. There are a few medications that are available for sickle cell disease. The first ones I have listed here are all medications you take by mouth or oral medications. The first one is hydroxyurea, which is the first one that I mentioned that was approved in 1998. And there's also folic acid and L-glutamine, which are more supplements. And then there is voxelotor. So voxelotor, it was approved in 2019. So there was a huge gap between 1998 and 2019 when hydroxyurea and voxelotor were approved. Voxelotor, like I said, is new on the market. It works well for patients, but there was a huge gap in the times that medications were available. Other treatments include prizmalizumab, which was approved at the same time as voxelotor. This is a medication that you receive via IV, so you have to come into a major institution such as University of Maryland or Hopkins, Washington Hospital Center, wherever that has an infusion center that's associated with it. And you get this infusion of this medication. You're there for 30 minutes to 2 hours in order to get your infusion, depending on how backed up the infusion center is. And this can be a major obstacle for a lot of patients. If patients are working, or if they have childcare issues, if they have transportation issues, coming into the hospital once a month in order to receive this medication can be a huge barrier for them. This medication works well, but not everybody is able to take the time that they need to be able to get this medication. Other treatments include blood transfusion, which is very important for people who experience anemia along with sickle cell disease. There's apheresis, which is another type of blood transfusion. And then there's bone marrow transplant. So bone marrow transplant is what the medical community considers to be curative for sickle cell disease. That being said, this is not the case for everyone. It happens with a lot of patients, but is not the case for everyone. So just putting that out there. Next slide, please. Who treats sickle cell disease? So often we'll get a patient that's coming into the hospital and is admitted, and we'll go and talk to them, ask who helps them with their sickle cell disease, who manages their medications. And sometimes people have just moved to the area, or they're young people who have just gone from pediatric to adult and haven't hooked up with an adult provider yet. And the first thing that we want to do is get them to a hematologist. A hematologist is a doctor who specializes in blood disorders. Hematology is the person that's going to be watching disease progress, prescribing disease-modifying medications such as hydroxyurea and crizanlizumab, voxelotor, the ones that I mentioned before. They are a very important part of the treatment team for someone with sickle cell disease. Next, we have your primary care provider. Sorry, thank you. Next, we have the primary care provider, who can be family medicine or internal medicine, as I have listed here. They are a good overall person for your health. Everybody should have a primary care provider, regardless if you have sickle cell disease. If you don't have any health problems at all, you should still have a primary care provider. They are also the gatekeeper for other specialties. People with sickle cell disease don't just experience pain, they experience these crises that can affect all different parts of their body, all different organs in their body, their heart, their lungs, their skin, anything. So internal medicine is who's going to be referring you to these different specialties. So it's very important to have. And then next we have emergency medicine. Last but not least, emergency medicine, patients with sickle cell disease will often experience pain crises. And sometimes these pain crises are so painful that they are not able to manage it with the medication that they have at home for their pain. So they will need to go to the emergency department in order to receive a different type of pain medication or a stronger pain medication. So emergency is very important for their care. With our patients, we try to get them to go to the emergency department that is affiliated with their hematologist so that that team knows them well. Next slide, please. So going back to the Ask Me 3 questions that was mentioned earlier, our problem is a 25-year-old woman who just started taking hydroxyurea. She is concerned about the very possible side effect of decreased fertility. So what's the problem here? This is a common medication that's used to treat sickle cell disease, but also has the side effect of decreased fertility. What do I need to do? Discuss fertility preservation with your hematologist or your primary care provider, and you may be referred to a provider that specializes in fertility. And why is this important for me to do? Whether you have sickle cell disease or any disease or no diseases at all, it's really important to be informed of what's going on medically with your care. You need to know. And being informed of your options can help you to make educated decisions and make the best decision for you and for your family. Next slide, please. So this is my final slide here. I would be remiss if I talked about sickle cell disease and did not talk about health disparities along with sickle cell disease. People with sickle cell disease tend to experience worse health outcomes compared to people with other diseases, and also have fewer access to health resources. There is a whole host of reasons for this, but the main reason is because this is a disease that mainly affects people of color, if we're just going to be honest. If we're going to talk about some of the health outcome disparities, the average life expectancy for people with the most severe form of sickle cell disease is 30 years shorter than people without sickle cell disease. Patients with sickle cell disease have the highest rate of return to the hospital within 30 days of discharge compared to other health conditions. The rate of stroke in adults with sickle cell disease is 3 times higher than their peers without sickle cell disease. The majority of sickle cell disease patients receive Medicaid benefits, and this is a huge problem because less than 70% of doctors in the United States are taking new patients with sickle cell disease. So this means that even if a patient is able to find a doctor who is going to take their insurance, they often face long wait times in order to be able to get in to see their doctor, which puts them behind with taking care of their disease and getting medication, and that can make the disease process speed up. Healthcare providers may inaccurately perceive patients with sickle cell disease as drug seeking, and in cases, which I hope rarely happens, but may often doubt the severity of their pain. As a result of this, patients with sickle cell disease often experience longer wait times to see a doctor and longer times to receive pain medication when they're in the emergency department. And last but not least, the number of physicians that are trained and willing to treat patients with SCD are extremely limited. And it's not because doctors aren't really willing, it's just because that the education and the research hasn't been there. So if the education's not there, there's really no way to train somebody on education that's not there. But going back to what I said at the beginning, this is an exciting time that we're in right now because we are really moving forward in the medical community and looking at sickle cell disease, doing so much research. So hopefully this time, 10 years from now, we'll be in a much better place. So I just want to end on that note, and I'm going to turn it back over. Thank you so much.
Thank you so very much. That was very enlightening. Interesting, very enlightening, and thought-provoking is the word I'm looking for, I think. All right, let me turn this over right now. Let's leave it right on that last slide to Tiana Wolford before we get to the resources, who will speak to us, as I said, from both a professional and personal perspective. Let's go back one slide and just stay on the, yeah.
Hello, everyone. I also would like to thank Ms. Donna and all of the organizers for having me and putting this whole thing together. Like Martine said, this is an incredible time to be a sickle cell patient and to be an advocate. You know, for so long in the sickle cell community, we've had to prioritize survival because we weren't even living well into adulthood. And like Martine said, now we are having access to new therapies. We have these 3 new FDA-approved drugs, and there's at least 70 coming down the pipeline that I am aware of. And because of the resilience of the community and advances in science, we as a sickle cell community now have the opportunity to prioritize things that have historically had to take a back burner, such as mental health and reproductive health. So like Ms. Donna said, I am the co-founder and CEO of the Sickle Cell Reproductive Health Education Directive, which is incredibly long, so we call it SC-RED for short. And my organization is actually the first and only sickle cell organization in the entire world to have a mission focused on reproductive health. And it's been amazing. It's taking off. You know, reproductive health is a hot topic and it touches everyone. So we've been able to do really well. But just a little bit of background about how I got here. I was diagnosed with sickle cell genotype SS through newborn screening. So my mother had the diagnosis before I was 3 months old. And, you know, she was in nursing school at the time and had already taken a particular interest in sickle cell. So I was blessed to be born into a family that at least knew what sickle cell was. The diagnosis was still a shock because it's very common in the sickle cell community for the mother to know her trait status, but the father does not know. And that's why I advocate for like genetic counseling and testing of not just the mother, but also the father. So, you know, it's one thing to read about sickle cell in a textbook, but it's another thing to have a child with it. But I think from an early age, what was instilled in me is that I could do anything with sickle cell. I just may have to do it differently. So I went to a predominantly white private institution from first grade to 12th grade. And they were very unapologetic about the fact that they knew nothing about sickle cell and unfortunately did not want to take the time to learn, which didn't really affect me until about middle school because growing up as a child, I did relatively well. I got admitted maybe once, twice a year for acute chest syndrome, which is the one of the most deadly complications you can have. And then around age 14, when I hit puberty and I went through delayed puberty, so I was maybe actually 15 when I started, but that's when I started spiraling out of control. I started having frequent pain crisis, and I had avascular necrosis, so bone damage and collapse in my hips. That's why I had the bilateral hip replacements before I was 15. And I also became transfusion dependent and started developing antibodies. So then I started rejecting the blood, and one of the transfusion reactions sent me into acute liver failure. And then, it was interesting because growing up in the pediatric setting, they empower you, the doctors, the social workers, the nurses, they really empower you to know like what narcotic and what dose works to treat your pain. But then when you transition into the adult care and you show up in the emergency room and you're asking for Dilaudid or morphine, then you are seen as a drug seeker. That is something that's pretty common, particularly in the emergency room. And so that transition was hard. And then what made it even more complicated was by the time I had graduated high school, I felt incredibly depressed and defeated. Like I just wasn't living the quality of life that I thought I deserved. So I actually, it wasn't even a doctor who approached us about this. It was one of my mother's students because she had transitioned from bedside nursing into teaching. And she asked us if we were aware of these clinical trials being done where they were doing haplo bone marrow transplants. So you didn't even need a perfect match. Either one of your parents or maybe even a sibling could be your donor. So I remember going in for a consult. I was 19 at the time. And, I looked at the doctor and we went through the informed consent process. And this sunny picture was painted like, do this transplant, your life is going to change. If you don't do it, I'm worried that you're going to die. And I remember saying, I'm willing to risk anything. I just don't want to be infertile. And he looked at me and he said, well, to be honest, with all the complications you've already had, you're probably already infertile and just don't know it. So hearing that at 19, it was definitely like a punch to the gut. And I went home and I did a Google search and I looked at education for egg freezing. And when I saw that it could be over $10,000, I looked at financial resources. And what I saw was like this amazing list of all of these private foundations that gave away grants for sperm banking and egg freezing, but you had to have a diagnosis of cancer, which is also another disparity because if I'm going through chemo and radiation, just like a cancer patient, I should have access to those same resources. So long story short, I kind of reconciled that if I was going to be cured from sickle cell, then maybe it was a fair trade to give up this dream of 5 biological children and I could just adopt. So I went through with the transplant. I did the chemo, the radiation, I had all of the side effects. And then about 3 months later, I spiked an incredibly high fever and my blood counts, my red and white counts just plummeted. And we didn't really understand why. And it turns out that I was rejecting the transplant and also had CMV virus, which contributed to the rejection. So I was in the hospital for 4 months and I was at risk for like bleeding and all types of infections. So it was a really scary time. And then at the end of the 4 months is when we learned that I had rejected the transplant. Like none of my mom's stem cells took. So it was a really, really devastating time. But fast forward to 2 years ago, when I was 29, I got a new hematologist. And it just so happens that she was one of the only hematologists in the world to be researching ovarian reserve and sickle cell, and particularly hydroxyurea and ovarian reserve. And she was like, it's weird that your transplant team haven't tested your fertility status. And so she tested it and she called me as soon as she got the results and she said that it was pretty dismal. I didn't really have any eggs. And she said, if you still want biological children, we need to freeze your eggs like tomorrow. So it was like this deja vu experience, because then I went back on Google, just like I had done 11 years prior, looking for financial resources. And it was really disheartening to see that there was no progress there. Everything was still for women and men with cancer. So, we spoke, and I originally just had this idea that I would start a foundation and give away grants for sperm banking and egg freezing, because now there's data that shows that hydroxyurea, which is our best research therapy, we knew it could cause low sperm count, but now we know that it can lower your ovarian reserve, and just disease progression, like injury to the ovaries, and now with the bone marrow transplants and now gene therapy, we are seeing a lot of sickle cell warriors experiencing infertility. So I thought I would just give away grants. And then talking to my hematologist, she really pointed out that this was a reproductive justice issue and that we needed to start making progress as far as legislation. And then I also had conversations with one of my long-term mentors. Her name is Dr. Kim Smith-Whitley. She is a pediatrician at CHOP. And she had been doing all of these speaking engagements about women's health and sickle cell for about a decade. So the three of us got together and we started SCRED. And so now we do more than just fertility. We address everything from delayed puberty to menopause and everything in between, like pregnancy and priapism, which is a reproductive health issue that the men with sickle cell experience. But, like Martine was saying, I think that this is an amazing time to be in this community, and we finally do have access to more resources. And I believe the next slide will list some of those.
Let's go. Yeah, there we are.
So while we have made a lot of progress, unfortunately, sickle cell is still underfunded. If you look at diseases like cystic fibrosis, where they have a much lower percentage of patients than we do, but they also have access to billions of dollars. So we have not made it there yet. I know we will soon. So just saying that to say that resources are still limited. There are over 150 community-based organizations in the United States that will help families with sickle cell with things like rent and gas bills and things like that. So,
Donna, I think we may have lost Tiana there.
We lost Tiana's visual for sure, and it sounded like we were going to get her back. Maybe Martine, until she comes back, do you want to pick up on the resources?
Yes. So there is sickle cell anemia, which provides sickle cell education and does a really great breakdown of what sickle cell is. There's also Sick Cells, which is a community-based organization that really provides resources for people living with sickle cell disease. There is also Sickle Red, which is Tiana's organization that she was describing to us. There's a lot of information on there regarding fertility and fertility preservation and legislation that's going on right now. And then there is the Maryland Sickle Cell Disease Association, which has support groups for patients in Maryland who are living with sickle cell disease. It's a great organization with a lot of information available on the website.
Okay. All right. Can we go to the next slide? All right. Before we get to Q&A, we've spoken a lot here about the unfortunate disparities that exist. Let me just tell the audience, as both speakers have said, an exciting time. The state of Maryland had a piece of legislation, Senator Hayes, Antonio Hayes, and the city was the key sponsor, called the Health Equities Resources Communities Act. And as part of that, there's a 2-year pilot program, pilot in quotes, called Pathways, and after which for successful recipients or new applicants, there's more stable funding. There are 9 grant recipients right now in the Pathways program. And I'm happy to say that one of those is the Johns Hopkins School of Medicine, together with quite a number of partners in Prince George's County. They received one of the larger grants at $2 million. The projects are just really getting underway. And I'll just briefly highlight what's happening here. It's a design that the Health Equity Resources Communities, HERC, are designed to fight disparities. And this is the first time that I've seen one focused on sickle cell in the history of the Maryland Community Health Resources Commission. I think I'm right about that. So it'll address disparities associated with the high prevalence of sickle cell disease and the lack of access to local comprehensive care for sickle cell disease in Prince George's County. Specific focus at this time, you had to have specific zip codes highly impacted by whatever target disease was the focus of the grant. So it's focused on Upper Marlboro, Laurel, and Capitol Heights. The project aims to reduce the number of individuals who present to the University of Maryland Capital Region Hospital. So again, a partnership amongst many with acute pain requiring hospital admission to improve access to sickle cell disease modifying treatment and transition services. Martine spoke about that transition between adolescent, young adult to adulthood, and to help reduce hospitalization. There will be a new infusion clinic at the University of Maryland Cap Region Medical Center to help patients. And there will be a cadre of community health workers who will do at least these 3 things: identify patients who don't have resources to facilitate access to care, help coordinate their care, and then provide sickle cell disease education. And then finally, there'll be a nurse navigator who can facilitate interventions to help address social determinants of health, which can often be as important in keeping someone healthy as physical health alone, and a nutritionist who will help develop a food plan for each participant. So in a nutshell, to reiterate the comment, now things are improving, and $2 million is a start in the state. That's a reasonably significant portion of the total funds that are available this round. And if that project succeeds and so shows good promise, there may be an opportunity for more stable funding in the future. So kudos to Maryland, to the state, for engaging this way. All right, so there are a couple of questions, and the first one that came in, Martine, maybe I'll pose to you. Oh, Tiana is back. Great. Tiana, can you hear us? This is great. We just went through some of the resources. So this one, really, I'd love your input, especially Tiana, on this. So the listener said, my best friend's daughter, this is why I think this is a compassionate person, it's not even her family, who is age 21, has sickle cell disease. Can you recommend ideas that I can use to help the family without invading their privacy or overstepping my friendship boundaries? For example, if you have sickle cell disease, what do you wish a friend would do for you? We'll take both your comments, but Tiana, maybe you can start.
Absolutely. I really love and appreciate this question. So one of the main things that I hear from the community and that I have felt and my family has felt is just not being seen, not being valued, and feeling isolated and just misunderstood. So I think the first step, you're already doing it, is just to show compassion and check in, because sickle cell can also be incredibly disruptive on your day to day, and it can take a toll on, as you said, not just the sickle cell warrior, but also their family as well, both mentally and physically. So just checking in, and maybe something like dropping off a meal, or maybe helping out with childcare or transportation. All of those things can go a really long way. And then I also know, from an advocacy standpoint, you don't have to be an advocate or an ally. I mean, you don't have to have sickle cell to be an advocate or an ally. So even something as simple as like going to the grocery store wearing a Sickle Cell Matters t-shirt, or just, raising awareness and I think one of the main things we want to do is kind of mainstream sickle cell and make it like a part of household discussions. So even just bringing it up in conversations and raising awareness, that also would go a long way.
Thank you. So, Martine, turning back to you, there's a question here about when someone's child is going to have the disease or when they might carry it. So can you talk about the trait versus the disease to clarify things?
Yeah, absolutely. So trait is when you are a carrier for the disease. If you have trait in some very extreme circumstances, something may happen to you where you will start to experience symptoms of sickle cell disease, but you have to be in a very extreme circumstance. But most people with trait never manifest any signs of symptoms of the disease. They are strictly a carrier of the disease. So if they were to have a partner that also has the disease, they would have a higher chance of having a child who has that disease. Now, just because you have trait or your child has trait does not mean that your child's child, your grandchild, will have trait or have the disease. Or if you have trait, that doesn't mean your child's going to have the disease or even have trait. Genes play out it's very hard to explain how genes play out, but just because you are a carrier does not mean that you are going to pass that trait on to your child or that your child will have sickle cell disease.
Thank you. Another question, is there such a thing as an ideal patient for a bone marrow transplant, or is it, circumstantial, whatever happens?
So there's no such thing as an ideal patient. If a patient's going to have a bone marrow transplant, you're looking at someone who is very compliant with their medications, meaning that they take all of their medications, they attend all of their doctor's appointments, they are doing everything that they are supposed to be doing in order to help diminish their disease process. This patient also ideally will have a family member that is a match and is willing to provide bone marrow for them, but really there really is no ideal patient.
So it isn't a matter of a certain set of symptoms or the grade of the disease or that sort of thing. So almost anyone could be eligible for it?
Anyone that is interested, we will refer to NIH, Hopkins, wherever, in order to look into the process of whether or not they are going to be someone that is going to be a candidate for a bone marrow transplant.
Tiana, this one's for you. Was your diagnosis as a result of a normal newborn screen, or was your mother a carrier and she wanted specifically to have you tested? And then a note here. Thank you very much for sharing your personal story.
Oh, thank you for listening. And that is a great question. So yes, I was diagnosed through newborn screening. My mother was told that my father did not have trait. So the assumption was I would either have trait or I would just have normal genotype. So yes, it was through newborn screening. And like I said, and Martine made this point too, we want everybody to make informed decisions. And so it's important that everybody know their trait status, not because we're trying to eradicate sickle cell and we're going to be telling people that if they have trait, they shouldn't, have a baby, but it's just important to be prepared and make informed decisions.
That's great. Martine, back to you. And I had this question myself. So it says, can you talk about some of the sickle cell disease drugs that are on the horizon? And let me finish this one, if you can. And even ones that were recently approved by the FDA. I believe the most recent drug costs over $125,000. So maybe touch on how organizationally, I love this part of the question, we might help support access to these given the financial disparities in the community.
Okay, so yes, the new drugs are very expensive. And even the ones that I talked about, like voxelotor, crizanlizumab only can be given through an infusion center. Voxelotor has to come from a specialty pharmacy. So that is also a barrier to patients getting it. There are a lot of drugs on the horizon. Mostly that are centered around decreasing the number of vaso-occlusive or pain crises that patients are having, and stopping the cell from sickling. Those are mostly where these medications are looking. As far as institutional support, advocacy is so important, like Tiana was saying. You have to, sickle cell needs a face. It needs people talking about it. And the more people that are talking about it, the more people are going to listen. If you're out there being an advocate for sickle cell, you're going to put sickle cell on the map, and people are going to hopefully be more willing to provide funding and access to care.
That's great. All right, here's a question, and maybe Tiana, maybe this is worth a comment in the chat if you know. So it says, my daughter has sickle cell and she's 23. At this age, there are lots of bumps and bruises, Tiana. We know you can identify along the way and along the life journey. We have not found a support group in the area that could be an excellent source for connecting with peers dealing with the same issues. I love the question in that I'm sure everyone would want support or to be able to commiserate or get ideas how to deal from others. Do either of you have any thoughts about support groups? Is there anything at the medical center, or Tiana, have you encountered anything?
Yes, so I do know that the Maryland organization that we had listed in the resources, they do have, I believe it's monthly meetups, and it's for warriors to get together. And then I know my organization at SC Red, we do these fireside chats, and it's been like a shared space. We do it for not just warriors, but then the caregivers. We do it for women, men, in the LGBT community, and the caregivers. And we try to keep it focused on reproductive health, but as you were saying, people have so much venting to do that it ends up taking all different kinds of turns and directions. So if I can put my email address in the chat, and then I'm happy to communicate and link you directly to some of these resources.
Put it in the Q&A and they'll be able to see that there. And again, let me remind everyone that you will, well, I'm going to get to it in a moment. You'll be able to see the entire presentation. Those were the questions that we have, but let me pick up on a word that I heard you use twice, Tiana, that I love, which is warrior. You're clearly a warrior. I think you're both warriors in this struggle, not just a provider, Martine, you're a warrior fighting in an arena that's really so important. Whenever I say we're at the last question, here come more. Having the trait. So I'm going to take this one or two and then we're going to stop. Having the trait, can you elaborate on what symptoms, if any, one may experience? I read a while ago about a child with a trait that died after doing strenuous exercise. I also read to be careful with sitting in the sun for too long.
Yeah, so with trait, it's any extreme. So if you're in extreme cold weather, if you're in extreme hot weather, if you're doing, some crazy aerobic exercise, if you are off in Colorado at an extreme elevation skiing, that can cause it. But it doesn't happen in everyone. But when it does, it's you have pain. Some people have shortness of breath. Some people have chest pain. But it's the symptoms of sickle cell disease when you experience it.
Thank you for that. And just in case anyone cannot see the Q&A, I think you can, but just to be clear, T Wolford, WOOLFORD at Sickle Cell Red, RED, all one word, .org is what she put in the chat. Well, let me say that was actually the last question. Let me say thank you to you all for joining us today, but most especially thank you to Tiana and Martine for sharing. Can we go to the next slide so I can provide everyone with information? As I mentioned at the beginning, Let's Talk About Health is a series, a community conversation. We've been doing these for a while. Listed there are all of the topics that we have put forward month to month here. We take off the summer months as people are busy. And so this was the first one resuming for the year. In about 48 hours, this presentation, this conversation, and the slides will be available at www.ums.org/Let's Talk. You can see this one or any of the others that have preceded at any time. And next month in October, our date is different. We're usually the third Wednesday in the month. Next month will be the fourth Wednesday at 12. Again, the topic will be sudden cardiac arrest. And we're going to talk about that as it's differentiated from a heart attack. So come back in. If you received an invitation to today, you should automatically receive an invitation henceforth moving forward for any of these. So again, thank you everyone for joining us, and most especially thank you, Martine and Tiana. Certainly appreciate you.
Thank you for having
Thank
us.
you.
Bye.